Today. My name is Patty Saberi. I am Associate Professor in the Division of Prevention Science at UCSF. And we are here for another installment of our Insights, which is the innovative non-traditional healthcare settings in HIV research lecture series. And the purpose of this series is to really look at research that's being done outside of the traditional healthcare setting. And as you'll see, we'll have two great speakers today who will speak on this. And this lecture series was funded by the UCSF CFAR Boost Award. So thank you very much to CFAR for their generosity. So we have two great speakers. We're going to start off with Dr. Yasaswi Kislovskiy, who's an assistant professor of obstetrics and gynecology. Dr. Kislovskiy joined UCSF in 2024. Her research seeks to incorporate the lived experience and community perspective in the understanding of research ethics, the reduction of stigma, and the creation of effective and sustainable change for communities facing structural barriers that perpetuate unmet needs in STIs, HIV, Hep C prevention, testing, and treatment. So Dr. Kislovskiy will describe her work and community-partnered work with U.S. sex workers and how this has led to her K-23 submission to reduce stigma that is the driving pharmacy-level barrier to PrEP access. And I just want to send her a huge good luck because her K-23 resubmission is being reviewed today, and she's already gotten a great score. So hopefully this will just be the last little bit of energy that it needs to be a shoo-in. So with that in mind, Dr. Kislovskiy, please take it away.
Like Prey said, my name is Yasaswi. I use she, her pronouns. I'm an assistant professor in the Department of OBGYN and Reproductive Sciences at UCSF. And I'll be talking about HIV prevention in community pharmacies, access and experiences from sex workers. Oh, right. And so I'm an OBGYN, but I did a fellowship in infectious disease. And then I also got a master's of science at the University of Pitt CTSI, which is where I trained. And I'm really happy to be here in San Francisco. I'm going to just mention our UCSF land acknowledgement. This is like a way to acknowledge the traditional custodians of this land, pay respects to them, and then also to thank them for the stewardship and support of this land. And I just want to highlight that Rochelle is going to put into the chat some more maybe robust ways to contribute to and acknowledge the history that's come before us and the present that we're in now. And so if you are so inclined, there's ways to donate or to get more involved there. So today I'll just be talking about some of the studies that I've done before and the data that led to the K-23 submission that Hari mentioned. So the first study is really to help me understand how US sex workers describe HIV prevention as really challenging. And I know there's been lots of work on that before, and hopefully the work that I had done will shed sort of additional nuance or insights into that. And then I'll talk about how pre-exposure PrEP or post-exposure PEP access in Pennsylvania and Georgia is limited, which is a finding that I did that I found after doing a simulated patient caller study across those two states, really inspired from the recommendations of sex workers from my first study. And then I'll talk about how intersectional stigma contributes to pharmacy level barriers to PrEP access. So in terms of US sex workers describing HIV prevention as challenging, and then this image I have to credit to the New Jersey Red Umbrella Alliance, and this quote, "Sex worker rights are human rights." And then this is like a really zoomed in picture of an umbrella, which is often used to describe places that are sex worker rights focused or sex worker friendly, a way to help people know what's safe. So this study I did during my fellowship in reproductive infectious disease, it was supported by the McGee Women's Research Institute. So I have a big thank you to that research organization for funding the work. published later in BMC Public Health, called HIV Awareness, Pre-Exposure Prophylaxis, Perceptions and Experience Among People Who Exchange Sex, Qualitative and Community-Based Participatory Study. And part of, I think, my own growth in working with the population of the community or individuals of sex workers is I think exchange sex is not really a phrase that we would use anymore, and we would call it sex work. So this was a community partnered qualitative study. And I think for those of you who are familiar with community-based or community participatory work, because this research idea was sort of coming from me and not from the community itself, I really chose to call it partnered rather than community-based. But essentially what I did was partner with about 5 or 6 either sex worker rights organizations or sex worker support organizations, and then had their compensated help from the beginning of study design all the way through data analysis. And so with community partners, I was able to review my interview guide before I did confidential in-depth interviews one-on-one. And then they were also able to review my recruitment methods, my recruitment flyers, and really just trying to make sure that I wasn't being harmful in any way to this group of folks. So this study kind of took place over the pandemic. So we kind of rapidly had to shift from one in-person interviews to Zoom-based interviews, but I actually found that to, not detract too much from the work itself. Ultimately, I had 22 participants, and I used inductive thematic analysis, and then after a round of iterative coding. So in terms of the themes, and I'm sorry, I'm being very brief. I have a slide if people are curious, more in-depth methods, but for the time that is allotted, I sort of thought I would give people an overview. But if there's any questions about the methods, I'm happy to share. So the themes that really arose, and then like I mentioned, I did member checking. So I really shared these with participants afterwards to make sure this sort of rang true to their perspectives. There were 5 main themes that arose from the work. The first was that appreciation of HIV risk and prevention strategies grew from information accumulated over time. 2, PrEP information came from a variety of sources with mixed messages and uncertain credibility. That decision-making about use of PrEP was relative to other behavioral decisions regarding exchange sex. Sorry for that typo. The multi-step process of obtaining PrEP presented multiple potential barriers, and healthcare providers were seen as powerful facilitators to PrEP utilization. And I'm really going to focus on this 4th theme, the multi-step process of obtaining PrEP presented multiple potential barriers, because I think it really led to sort of the next work that I did. Just to explain in more detail, when participants were explaining the multiple steps to obtain PrEP, they were really describing that they have to do so many things, each of which has multiple barriers and opportunities for feelings of discrimination. Or barriers to either just not getting an appointment or not being able to get the thing they needed. And they specifically pointed to the fact that they have to get an appointment with someone who prescribes PrEP. So they may have had a family doctor or another sort of health or community center that they would traditionally go to for their care. But then that place wouldn't prescribe PrEP. So they had to specifically seek out someone that would prescribe PrEP in particular. And then be able to secure an appointment with that person. Then after meeting with that PrEP prescriber, they specifically pointed out that they would have to feel comfortable even discussing PrEP or being able to ask for it with that person. And then a lot of participants felt like they were really worried about the cost of filling the prescription. And then, this was in my 2nd year of fellowship, so this was, really wonderful exploratory work for me. They were describing a lot of pharmacy challenges. They were saying that they would go to the pharmacy and then the PrEP would be out of stock and they would have had no idea until they showed up. And then this led to interruptions of PrEP use. And one participant in particular described that as heartbreaking because when they weren't on PrEP, they didn't feel safe doing their job, which is sex work. And when they were already dealing with kind of intense financial insecurity, without this medicine, they couldn't gain money to continue supporting their life. Other people talked about when they went to rural pharmacies, for example, if they were going home to their family of origin in a rural county away from their urban center that they typically live and work in, that rural pharmacies just don't stock PrEP at all. And some people even described this feeling of needing to like stock up or like get a lot of PrEP prescriptions filled before they went back to their family location. And then no matter where people were, urban or rural, they were worried about stigma associated with PrEP use. One participant in particular described, feeling like if they came to fill the prescription at the pharmacy that they might be judged about picking it up, or that when they went to the pharmacy to request that the prescription be filled, they had a lot of fear about how the pharmacist would react to them or the pharmacy staff in general. And then there's also a layer of sort of race-based discrimination and racism. People felt like if they were in line at a pharmacy and they themselves are, presenting as someone who might be Black, that the pharmacy staff might not give them a medication, whereas another person in line who presents as someone who appears white would be given that same prescription, sort of feeling mistrust with the pharmacy staff that they are actually giving equitable access to medicines, and rather that they're withholding medications based on racist beliefs. So this was really kind of eye-opening for me. I'm an OBGYN. I really came to this work working to understand, what kinds of health barriers sex workers are facing, trying to understand a group of patients that I had had over the years that I just felt like I wasn't connecting with, that I wasn't meeting their needs in a sincere way. And when I did this work and they were sharing these kinds of challenges with me, I thought, like this is something that we could really try to understand, unpack, and hopefully intervene on. And that really led to the next study that I did. So PrEP, really trying to understand PrEP and PEP access in Pennsylvania, where I was living and working at the time, and then also finding some partners in Georgia who had pharmacy expertise, led to this 2-state study. And this work, I have to thank the Emory University Center for AIDS Research, which generously supported this work. It was then published in the Journal of American Pharmacists Association. And I have to really thank Marian Jarlinski and Natalie Crawford, Marian who's at Pitt and Natalie who's at Emory, for supporting this work. So what we did in this study was a simulated patient caller study, and we did a cross-sectional design. And so what we did is there are state-maintained lists of pharmacies that are you can get for a nominal fee, and we obtained both lists from Georgia and Pennsylvania, and then isolated out of the combined 2-state, there's like around 6,600 pharmacies. We then allocated between rural and urban locations. So I was really trying to understand in this case, what is the availability of PrEP for same-day pickup? Like if you walked up to a pharmacy, could you get it? And then second, would it matter if you were an urban or rural location? And then third, what if you were an ending HIV epidemic jurisdiction? Would that be protective, meaning you'd have more access to PrEP comparatively? So those were kind of the 3 main questions we were trying to consider. So ultimately, we called so there were about 1,300 rural located pharmacies and about 4,200 urban located pharmacies. We called 278 rural ones and 255 urban ones. We did end up finding that these lists maintained by the states were not always that accurate. So the most common reason for exclusion in both groups was that the pharmacy was actually not a retail pharmacy. It was more likely to be like a hospital-based pharmacy or like a long-term infusion center. Those are the 2 kinds of non-retail pharmacies, like a place you couldn't just walk up and get a script filled. And then some of them, just didn't pick up the phone. We tried 3 times and then they came off our list. And then we also really specific in the call protocol, where the research assistants would try to speak specifically to a pharmacist. And if they couldn't really get to that person, that pharmacy was excluded. So we included 262 rural pharmacies and 219 urban pharmacies. So PrEP and PEP were hard to access overall. And in both states, inclusive of both states, only 3 out of 10 pharmacies typically would have PrEP available for same-day pickup. So you can see in this table that for the PrEP group, that 148 pharmacies had it available and 333 had it not available. And then for the post-exposure prophylaxis, only 1 out of 10 pharmacies had it for same-day pickup. So 48 had PEP for same-day pickup, and then 407 did not have it. And so the next thing we tried to understand was what's the difference if you're in a rural or in a EHE county. So rural pharmacies, only 1 out of 5 had PrEP in stock. Urban pharmacies, only 4 out of 10 had PrEP in stock. And pharmacies in EHE counties, 6 out of 10. So we did find that there were more pharmacies in EHE counties, but I feel like still like 6 out of 10 in an ending HIV epidemic jurisdiction, like I would really hope for it to be like 10 out of 10 or 9 out of 10. So then we tried to understand, okay, is it easier if you're in an urban place or in an EHE county? And it is. So in urban counties, the unadjusted odds ratio was 2.77 times more likely than in a rural county to have PrEP for same-day pickup. And then we did also adjust for both racial composition of that county and by Black racial composition, and then chain pharmacy status. And so chain pharmacies were defined as pharmacies that have a parent company that's ranked in like the top 25 US pharmacies by number of pharmacist employees. So we were thinking of like our Safeway or Walgreens or Costco pharmacies, kind of wondering if having a large corporate base enhances either the stock available or the ability to refill or what have you. But even after adjusting for that, it was still true that you were around 2 times more likely in an urban county to have PrEP for same-day pickup than in a rural county. And then EHE counties still, after adjustment, were 2.55 times more likely to have PrEP than in a non-EHE county. So even though the overall access to me is quite low, urban and EHE seem to be better. So this was like a really helpful study to clarify, like, yes, rural pharmacies are, not having the same level of access that you might get in an urban pharmacy. But another thing that really emerged from the data was how the simulated patients were treated during the phone calls. And so we would do these, study meetings with the simulated patients who are research assistants who are, being paid for their summer work. And just as they were going through, they were describing a lot of hard interactions on the phone. And we ultimately started having people take notes about what their experiences were, what the pharmacist might have said. And I want to be really clear that we didn't record the pharmacists because we didn't have their consent. That's not ethical. It's not legal in Pennsylvania anyway. Although I have seen simulated patient caller studies, for example, in Utah, where they did record pharmacies because you are allowed to record people without consent in other states. It's not true for me. So this is really note-taking that the research assistants had done. So what emerged from this data, and this is, I'm currently analyzing this data and will seek publication hopefully soon. But, broadly, that the simulated patients were in their notes on stigmatizing communications from pharmacists, that there was sort of intersectional stigma going on. That, for example, related to PrEP itself, the pharmacist said, "Are you kidding? Who uses that stuff?" Or this other simulated patient mentioned, they asked me, "What is this disease for?" And then when they looked it up on the computer, the pharmacist then said, "Oh no, we don't carry anything like that." And then related to gender, that one simulated patient said, the pharmacist assumed I was a woman, and then after I realized they realized that I was asking for PrEP, they asked if I was on birth control. So really linking maybe someone's reproductive future with their, maybe their right to have children with whether or not they're using PrEP. And then another pharmacist outright told a simulated patient that PrEP is not for women. And then in terms of sexual behavior, a simulated patient commented that the pharmacist asked if they had a partner with HIV. And then the way in which that was communicated, the simulated patient felt really judged. Like, they were asking why I was taking PrEP, or that I needed to that simulated patient needed to disclose their behavioral indication for PrEP to the pharmacist. So all of this led to a lot of there was also some, kind of really frequent in the group of simulated patients. One person identified as gender diverse and felt a lot of gender dysphoria when doing the work, and would kind of repetitively be assumed to be an incorrect gender. And we actually, in my work as the PI, took that person out of phone calls because it was too gender dysphoric for them to keep doing it. So I think for me, going back to the original work that I had done, those 5 themes, the fifth theme was really how powerful healthcare providers are in sort of mediating someone's interest in HIV prevention. And so understanding that, access is really hard, pharmacies don't seem to be stocking it. But for this group of people who are they've finally gone through all these steps of, getting the prescription, feeling secure in their funds to be able to afford the prescription, and then actually, showing up to or calling to pharmacy saying, can I get this script? That there was still this final barrier in this patient provider communication space. And this seemed like a really helpful place to maybe support pharmacy colleagues in, unpacking that intersectional stigma and helping to reduce it. So for the K23 that Parya mentioned that is undergoing scoring today, really the goal is to understand better, what are the pharmacist's perspectives around the space, prescribing or filling these medications, and then how could we adapt an existing anti-stigma intervention to pharmacy spaces, and then to pilot that anti-stigma intervention to see how effective it might be. So in terms of future directions, I already mentioned this first one, that I'm hoping to intervene to improve pharmacy patient communication and reduce intersectional stigma. And I think broadly, these 2 pieces of work have kind of shown me that it's worth it to evaluate other stigmatized medications like buprenorphine to help treat substance use, abortion medications, birth control medications. And really, the simulated patient caller study was inspired by Dr. Marian Jarlinski's work around emergency contraception and its lack of access in pharmacies. I'd also love to evaluate other healthcare spaces that may contribute to discrimination. So in my original qualitative study, people described, challenging interactions in emergency rooms, waiting rooms, and during registration processes. And I also have to underscore the importance of community partnered research. I really owe all of this work to the participants that were willing to talk to me during my fellowship in my first fellowship study. And I can't express that gratitude enough. And I hope to continue doing community partnered work for as long as I'm a researcher. And then I think in that first set of themes, participants also kind of talked about how they get information around HIV prevention from so many different sources, whether that's a bus poster or a public health fair or a peer mentor that's really useful to them. And that really showed me that varying dissemination strategies for HIV prevention information is really important. And I'd love to support that both as a doctor in my clinical work and as a researcher. And lastly, and especially topical for this group and this talk, is to explore other non-traditional ways to provide preventive healthcare. There's really lovely data in international context around peer-led HIV prevention mechanisms. And so I think that's an opportunity. And then these other sort of spaces like the emergency room, the waiting room, the registration process, rather than thinking of them as places that only cause harm, I think that they're actually really wonderful opportunities to maybe change into preventive supportive care. So I would love any questions. Thank you so much for your time.
Thank you so much. That was amazing.
Fabulous.
Just in the
Go ahead,
interest of
Patty.
time, I'm just going to ask the couple of questions that came up in the chat, and then we can move on to our second speaker and then come back again, if that's okay with you. Yes, this way. So one of the questions that came up was the stigmatizing language that was used. Was that seen mainly in rural, urban, or both types of pharmacies?
So it was seen in both.
Okay. Was
And then,
there any difference?
yeah, I'm still analyzing that data. And so because qualitative data is like kind of not generalizable in that way, I'm hesitant to make like group-based comparisons. But just from like my original pass through the data, it definitely happened in both because I was curious about the same thing. Yeah.
Great. And then when the one response that was given about how this is not for women, which I'm assuming they meant cisgender women, was that around Descovy maybe, or like what was, or was?
Yeah, so the call script would have people start asking about Truvada, and then they would shift to Descovy. So it was inclusive of both. So I wouldn't be able to stratify if a pharmacist was saying Descovy is not meant for them. But I would say from my from being in the study and listening to the call, like the simulated patients in our study debriefs, they were talking about PrEP in general. There was a lot of pharmacists who had not heard about PrEP. And I think they would sort of hear the call, the pharmacist would get the call and say, oh, okay. And then the simulated patient would hear a bunch of typing. And then the pharmacist would get back on and say like, oh, okay, so we carry Truvada and proceed with the call. So I think there was some like information gathering by the pharmacist during the call to understand like what PrEP is. And this really took place in Pennsylvania and Georgia, and those two states don't have pharmacist protections to prescribe PrEP. And I saw that in the chat. So just to explain.
Yeah. And this first series of interviews where you got the themes, that was also Pennsylvania and Georgia as well.
US based, but we didn't collect geographic data to protect participant confidentiality. So beyond sort of containing it to the US, I can't tell you where in the US it happened.
Okay. Well, thank you so much again. And we're going to come back to you. So if there's more questions, if y'all can either put in the chat or can hold on until we have hear about our next speaker. Thank you so much, Yasaswi. So we have now Dr. Abubaker Saeed, who's an assistant professor of pharmacy practice at Harvard University. So he's going to be talking about the impact of an intervention to reduce pharmacists' racial bias toward people of color at risk of HIV. So Dr. Abubaker Saeed has an interest that lies in the newly emerging field of pharmacoequity science, which I had to look up because I didn't know about it either. So amazing, which addresses the lack of equitable access to and use of evidence-based medical treatments for disadvantaged populations. And his research focuses on the development and implementation of pharmacy-based interventions to reduce healthcare disparities in HIV treatment and prevention. And I'm so excited. And Dr. Saeed is one of Dr. Jessica Haber's mentees. So it's amazing to see all the great work that Dr. Haber is doing continue as well. So with that, Dr. Saeed, please take it away.
The impact of interventions to reduce pharmacists' racial bias towards people of colors at risk of HIV. I hope you are seeing my slide very well.
You look perfect. Thank you so much.
Which is a KO1 award supported by the National Institute of Mental Health. And just an introduction to the topic, about racial disparities in HIV PrEP cares. People of colors experience substantial disparities in the whole pre-exposure prophylaxis care continuum. And for example, according to CDC data, 66% of the white eligible for PrEP, receive prescriptions compared to 26 of people of colors. And there are 14 states in the country have passed laws enabling pharmacists to independently prescribe PrEP up to now, and more states are expected to give the pharmacists this authority. Implicit racial bias has an impact on patient-providers interactions, on treatment decisions and adherence to medications and outcome of treatment in general. implicit basis among pharmacists can diminish the effectiveness of the promising pharmacy-based PrEP program in the future. And for example, for a national study that assessed the associations between student implicit racism and the assumption about the patient behaviors regarding sexual behaviors or adherence to PrEP, participants randomly assigned to 1 or 2 experimental cases of black and white PrEP candidate. The finding of the study indicate that high implicit racism was associated with high assumption about black non-adherence to PrEP. The prejudice habits breaking intervention, which is an evidence-based interventions that deal with implicit bias as a habit that can be broken through consistent effort. And it is based on a solid scientific model of cognitive behavioral change. Actually train the individuals on multiple implicit bias mitigation strategies. We can see in the slide. It produced long-term, unlike other interventions designed to mitigate or reduce implicit bias. It had a long-term behavioral change indicated in increase of awareness of bias or concern about discriminations and reductions in the magnitude of implicit bias. Our specific aim in this project is to understand the potential determinant for implementation of these interventions and to adapt the interventions to fit the community pharmacy settings, and then to determine the acceptability, visibility, and preliminary impact of the adapted intervention. For aim 1, for the whole study, we are going to apply the adapted ITT models, which is a model designed to facilitate the adaptations of evidence base without contradicting their core element or theoretical foundations. As you see here, we align the 8 steps of these models with our objective. For example, for the first 3 phases of the models, assessment, decision, administrations, is aligned with the first aim, in which we are going to conduct a qualitative study to elicit the participant or the stakeholders' opinion about the determinant of the implementation of the interventions. And the third phases of the model align with aim 2, which is concerned with the adaptation process of the interventions. And the last 2 phases actually is aligned with testing the acceptability and visibility of the intervention, as well as assessing the primary impact of this intervention. For aim 1, we are going to conduct a qualitative study among community pharmacy located in the Suffolk County in Boston. All stakeholders will be included are the pharmacy interns, the pharmacy managers, and pharmacy policymakers. We are going to utilize criteria sampling strategy to ensure the diversity of the stakeholders, stratify participants by demographic characteristic, and enroll participants meeting this criteria until a saturation point. We're estimating that 25 pharmacy interns and 10 pharmacy managers and 5 pharmacy policymakers to participate in this aim. We are going to conduct we are going to conduct theater testings, which is to present the original interventions to the stakeholder to obtain a feedback for the context-specific modification and future implementations. Before each focus group discussions, we present the original intervention component as well as the simulations. We are suggesting to use simulations as adaptation for delivery of the interventions, as we can see in the coming slides. For the original interventions, it is composed of educational component and a training component. For the educational component, the intervention introduced prejudice as a habit and how bias are developed unintentionally, and then discuss the prevalence of implicit bias and how they lead to unintentionally perpetuating discriminations, and also discuss research linking implicit bias to a wide range of disparity across multiple domains. For the practical part of the original interventions, actually the interventions introduce 5 implicit bias mitigation strategies. Here, as you see from the table, contact, which for example increase exposure to out group members, and stereotypic replacement, counter stereotypic imaging, and individualization, viewing others, for example, according to their personal rather than stereotypic characteristics, and perspective taking. These strategies are illustrated with examples of everyday situations in which a strategy can be used, and the participants are asked to provide an example of a situation in which a certain strategy can be applied. Participants are expected to practice these strategies in real-life situations and provide feedback. Our suggested mode of delivery for the interventions through simulations start with and end with 5 minutes mindfulness activities, and to introduce each strategy as a separate case scenario. The case will involve a counseling session between a pharmacist and a male or female Black or Latinx actors who is considered PrEP for the first time as an standardized patient. The scenario will address, in addition to this, cross-sectional communications, structural element of patient-provider difference, using of active listening, and need for interpreters, and use of method to overcome barriers in communications. The interview guide for the group discussion will be based on the domain of health equity implementation framework, which is a comprehensive framework for identifying determinant of evidence-based interventions implementation, as well as healthcare disparities domains. So it is, in our case, it represents a ideal framework to inform the adaptations of our interventions for implicit bias against PrEP prescriptions for people of colors. As you see, the framework deals with upstreams domain like societal influence, socio-political forces, and economics, as well as the locals and as well as the local domain regarding the community pharmacy context, as well as individual characteristics of the interventions and the factors that may impact pharmacists or determinant of the intervention implementations in the view of pharmacy managers and policymakers. The second aim is involve a detailed step of adaptations, which is started by phases productions, in which we are going to create an adaptation plan to document considered options and decisions to produce draft 1 using data from M1 adjusted. We are going to adjust the content of the interventions or regional interventions. For example, selecting one or more implicit bias mitigation strategies, and confirms the simulations to be used as a delivery for the interventions. The second phase is involve topical experts, provide topic expert with a background on the study aims, the content of the interventions, original interventions, and a summary of feedback from the theater tests and the content of draft 1. And then we conduct a meeting with experts to discuss their suggestions. The third field in the adaptation process is the integrations. We are going to refine the expert input and integrate it into draft 1 to produce draft 2. Integrate readability testings in the adapted interventions to increase the comprehensions for pharmacy interns. And then we are going to conduct a theater testing for draft 2 with 10 PrEP users who are people of colors, obtain feedback using an open-ended questionnaire, refine and incorporate their input to produce draft 3. Then we are going to conduct theater testing for draft 3 with 10 intern, 2 pharmacy managers and 2 pharmacy policymakers, and obtain their feedback using an open-ended questionnaires, refine and incorporate their input to produce the final versions of the intervention of the adapted intervention. In M3, we are going, as I said, to determine the acceptability and visibility and preliminary impact of the adapted interventions. Actually, we are going to screen pharmacy intern using a standardized test for racial implicit bias and divide them into 2 groups: interventions arm and control arms. The intervention arm is going to take the virtual adapted interventions, and the control arm they are going to assign to an online course on implicit bias. The online course for the implicit bias for the control group is a 3-model design to teach the users what is bias, how to recognize it, and how to minimize its impact. For the intervention group, will be instructed to practice anti-bias strategies as much as possible, apply them in real-life situations, record the numbers of practices in a diary to provide the feedback at the end of the study. Then we are going to assess after 8 weeks both group for the intervention groups. We assess the acceptability and visibility, and for both groups we are going to assess again the race test, implicit bias race test, and concern about discriminations. For the outcome implementation outcome acceptability will be assessed by the acceptability of intervention measures, as well as an open-ended questionnaire to identify participant perceptions about acceptability and barriers and recommendation for further improvement. So regarding visibility, the visibility will be also assessed by the visibility of interventions measures, as well as evaluation of the process measure of visibility, including recruitment and rate of completion of each component of intervention. With regard to the preliminary impact, we are going, as I said, to assess reductions in racial implicit bias score and concern about discrimination among pharmacy interns using implicit bias association test, and concern about discrimination scales in 8-week post intervention implementations. The intervention is expected to be acceptable and visible and will reduce pharmacy intern implicit bias together with improving their cultural competency to provide equitable pharmaceutical care for people of colors. And the finding, we hope that will inform an R01 study to help reduce the existing disparities in prescribing PrEP and decreasing HIV transmission among disadvantaged populations. And this is my mentoring team and advisors, and I thank them very much for their effort they did with me through a couple of months to come up with this project. And thank you for listening.
Thank you, Abubaker. Amazing. I actually, if folks have questions, please feel free to put them in chat or please raise your hand. And I actually was just wondering if you can give a little bit of background of like how you decided, because I'm still kind of curious what research or what you did prior to this that led you to working with this particular group.
Actually, I started my research working on infectious disease as a pharmacist during overseas in my country there, studying tuberculosis, for example, in my master, prescribing patterns, and also I developed some sort of policy or proposed a policy for surgical prophylaxis in my PhD. And all the work I did regarding the tuberculosis or the one that I did in the PhD is actually involving disadvantaged populations. So I combine these both infectious disease and disadvantaged populations to come up with a theme for my research, or that to go through, to work on pharmacy-based interventions that address disparities in health cares. And I select HIV. You know that HIV is a disease that killing millions of people around the globe.
Thank you. And Abubaker, sorry, would it be possible to stop sharing your screen so we can just see everyone?
Okay.
If that's possible. Yeah, so I'm just going to invite everyone. We have 10 more minutes if you have any questions. And there's lots of great comments for both you and Yasaswi in the chat about how interesting your research is. So I'm just going to invite folks to raise their hands. And I think Rochelle is just launched a feedback survey. If y'all could also please take that, that will help us for future presentations. But please feel free to come off mute to ask your questions.
Hi, Dr. Saeed. Damien Denson. I was curious why, I think I understand you focus on pharmacy interns as they're in training. But I think based on Yasaswi, I'm sorry, I can't pronounce your, I'm gonna mess up your name. The first presenter, her presentation just points to the importance of pharmacists working and learning about these types of biases. So if there is why you chose pharmacy interns, and if there is any consideration for pharmacists in practice for this type of intervention.
Yeah, and Damien, is this question for anyone, or was it toward Yasaswi?
This is Dr. Saeed.
Oh, Dr. Saeed, okay.
Yes.
Thank you very much for the question. Actually, the question is, we select the pharmacist intern, and we are lucky to do so due to logistical reason. We have a correspondence before the grant submission, like more than 6 months with one of the chain pharmacy here in Boston, but they apologize at 1 week before the submissions. So we turn to the pharmacist intern, and the justifications that the pharmacist interns actually, they are a practitioner, by the way, and for example, some of them in the coming year will be a regular pharmacy or a licensed pharmacy.
Thank you for that question, Damien. And also, I just wanted to say real quick, I have 2 student pharmacists at UCSF who just did similar research among student pharmacies, and there's a lot of stigma among student pharmacies, which is actually more associated with attitudes toward PrEP prescribing in the future. So there's also this move to not just address currently working pharmacists, but the ones that are going to be prescribing PrEP in the near future, to really have a solid curriculum for future pharmacists. Yeah, great question. Any other questions, folks? I actually had a question. I wanted to go back to Yasaswi's presentation around your qualitative research with sex workers that you did. I was just wondering if there are any other themes that came up that you are good to highlight or intervene on for future projects, because it looked like there was a bunch of other themes that came up. And you're on mute.
Thank you. Yes. Sorry. Thank you so much for that question. Yeah, having the privilege to do that work is like one of the nicest things I've done in my work so far. I do think there's probably 2 other themes that are worth highlighting, and I can share that slide again if that's helpful to people. One is the first theme that appreciation of HIV risk and prevention strategies grew from information accumulated over time. So one thing that came out was that sex workers identified that HIV prevention was one of the most important concerns that they had in terms of keeping themselves safe during sex work. So I found that really profound, that like people really wanted to not get HIV, and they were really, battling through a very confusing system to get effective person-centered HIV prevention, like in front of them at the right time. So I thought that was really important. And then I think I've touched on this a little bit, but the fifth theme, that healthcare providers were seen as powerful facilitators to PrEP utilization, is also really important. I think it can sometimes feel like, because of the historical problematic way healthcare professionals have been involved, or, even in my second study, I sort of talked about how there's a lot of communicated discrimination constituting intersectional stigma. People can feel like discouraged to get involved in this kind of work. But actually, in this theme, participants were really explaining that like non-judgmental, supportive, open communication with like a healthcare professional was really important to them, to help them make a healthcare decision that was right for them in terms of supporting condom use or helping them get access to PrEP, or what have you. And I feel like that's just really an important opportunity for all of us to feel like motivated to do this work. That one, people don't want HIV and they want to do the things they need that would help them not get it. And two, that as healthcare professionals, we have this really powerful ability to communicate effectively, non-judgmentally, and have that have a lasting impact on someone's life.
Thank you so much. That was really great. And Abubaker, I'm just wondering for you, I know you didn't present any data, but I was just wondering where you are in all your aims and if you have any preliminary data to share. You're on mute.
The award started this September, and we are in the preparation phase of the qualitative part, preparing for the simulation video, and we find that it is a very, theoretically we have proposed it, but practically it needs much of effort in order to design the scenarios for the implementation, bias mitigation strategies, and other stuff. But
Yeah.
we will be happy if we have some sort of result to present it in this platform.
Yeah, that's really difficult. I'm actually just working on another project on stigma among nurses, and the videos for simulated patients is so difficult. So kudos to you for taking that up. Any other questions, folks? All right. Well, if we have no more questions, we can adjourn 3 minutes early. And just thanking again our wonderful speakers, Dr. Abubaker Saeed and Dr. Yasaswi Kislovskiy. Thank you again for your time. And we have